Okay, so while I do like arguing, I don't know that I'll be able to debate this topic too well, because as you'd say, I don't really have a horse in this race since I do all three of these, and I think they're complementary procedures and can certainly be seen that way. That said, I will make an argument for TCAR as being a type of therapy that we all should have in our practice. These are my disclosures. So the first thing I'll say is that certainly by the time we got to CREST 2, Act 1, the techniques of carotid artery stenting as well as carotid endarterectomy have been fairly well established, and the nice thing about these trials, these large randomized trials, in addition to the trials in the 80s and 90s, is that they basically demonstrated that these therapies are equivalent in terms of some of the most relevant endpoints, such as our composite endpoints of stroke, death, and MI. And so both Act 1 and CREST really showed that these therapies are good therapies. They do work well at stroke prevention, and they have relatively low complication rates by the time we got to these randomized trials. That said, is there room for improvement? And if you look at the CREST trial, I think you could argue that there is. So although there was no difference between the two arms in terms of the composite endpoint of stroke, death, and MI, when you look at carotid endarterectomy, we certainly saw a higher rate of MI, generally because of the general anesthesia, and a higher rate of nerve injuries with patients undergoing CEA. On the other hand, if you look at all stroke, this is where, as we've heard from Dr. Sucker, this is an area where carotid stenting still falls short of carotid endarterectomy. So the composite endpoints may be the same, but each of these two modalities have their sort of strong points and weak points. So primary endpoint the same in these, but all stroke at 30 days, significantly higher in CAS in the CREST trial. All stroke and major ipsilateral stroke, significantly higher all the way out to 4 years. And so that really highlights the fact that carotid endarterectomy, although it is a good procedure, it has the lowest stroke risk compared to CAS or transfemoral stenting. It does require extensive dissection of the internal carotid and carotid bulb. That comes with it a risk of nerve injury, which is generally about 5 to 7% in most trials. It usually requires general anesthesia. Not many of us do cervical blocks for this, although that's feasible. Most of us will use general anesthesia, and that brings a certain degree of cardiovascular morbidity, as well as a 2 to 3 hour OR time, except in perhaps people who do eversions routinely, so longer operative time. On the flip side of that, transfemoral carotid stenting is a procedure which has a lower cardiovascular morbidity, primarily because of the fact that you do these under local anesthesia with the patient wide awake. 30 to 60-minute procedure time is probably on the long side for most of these procedures, so they're nice and quick. But the issues with carotid stenting, transfemoral stenting, are some of the issues we already heard about: crossing the arch, and I'll get into that a little bit in terms of bilateral embolic events, absence of some of the surgical protections, and just the overall high stroke rate relative to CEA. And that's where the idea of cervical carotid revascularization really shows some promise. And this procedure, as we already heard, it's done through a very small 1 to 2 centimeter incision. This is definitely a different incision than you have for an endarterectomy. Most of us do this under local anesthesia, although some do still prefer to do this under general for various reasons. And it involves a flow reversal circuit from the carotid artery to the femoral vein that gives it some inherent protections compared to other embolic protection modalities. So the three main, I think there's several different ways you can look at the benefits of TCAR. The first has to do with protection from stroke, and I think the second set of benefits has to do with the patient experience to some degree. So in terms of the prevention of stroke, I think there's three main areas that are important. Number one, we establish embolic protection before we cross the lesion, and I think this is important, and any proximal protection strategy does this. Flow reversal is akin to the surgical back bleeding, which is a benefit that if you haven't done an endarterectomy and flushed out that artery, you kind of don't appreciate how important that can be. And then finally, TCAR allows us to avoid the arch, as we already briefly heard about. So certainly establishing embolic protection before crossing lesion is critical. There are embolic events at all points in a transfemoral stenting procedure. That comes at the time of sheath placement, wiring across a lesion, even putting up an embolic protection device. And so no point of this procedure is safe from embolization, and that's why establishing proximal protection before crossing lesion is one of the best ways we can mitigate the risk of embolic issues. In terms of the flow reversal gives us a situation analogous to surgical back bleeding. So after we've completed an endarterectomy and we clean out the artery and we sew on the patch, we open up both sides of the artery and let it back bleed. So any debris that was able to sort of get into the crevices of the ends of our dissection is washed out very vigorously. This is important, and when we think about a transfemoral stenting procedure, we can have thrombus above the filter itself. Some of the components of a lesion that we're plasting are very soft and can go through the variable pore size of embolic protection devices. And so, not having the ability to backflush this is really a downside of transfemoral stenting, and I think that's one of the advantages of the flow reversal concept. And then finally, avoiding the arch, I think, is of paramount importance. DW MRI lesions, as we've already discussed, are almost ubiquitous with carotid stenting procedures. They happen with all carotid interventions, there's no doubt about that, but the incidence and the location varies depending on what we're doing. And as mentioned, there's evidence of cognitive decline that has been shown to be associated with these new WD-MRI lesions. So I don't think these lesions are silent lesions that have no consequence. There's growing literature that they certainly do have consequence. And when you look at the incidence of these new lesions, certainly CEA seems to have the lowest incidence of these. So patients undergoing CEA have about a 20% rate of new DWMRI lesions. When we look at transfemoral stenting, these lesions are almost ubiquitous and they're bilateral, which is a real problem. Now, when we do transfemoral stenting with proximal embolic protection, this is where we can see a dramatic reduction in these lesions. So again, it suggests that establishing protection before we cross the lesion can be very important at reducing the risk of embolic issues. But it's only when we get to the TCAR procedure where we're avoiding the opposite side, we're avoiding the arch, and we're establishing that proximal protection and probably adding the flow reversal where we get new MRI lesions that are akin to those we see with carotid endarterectomy. So I think this kind of data really highlights one of the real advantages of this type of approach. And then finally, in terms of the patient experience or the surgeon and patient experience, I think that TCAR adds some additional advantages in the sense that it minimizes dissection around the cranial nerves. The incision is smaller. The patients really do see a difference between a CEA incision, which can be 4, 5, 6 centimeters, versus this very small 1 to 2 centimeter incision just above the collarbone. This is true from a pain standpoint. It's true from a cosmetic standpoint. And in terms of the operative experience for the interventionalist or the surgeon, the operative times in these procedures are extremely fast. They're really akin to more of a carotid stent procedure rather than an endarterectomy. And that has to do with the fact that we're not putting the patient to sleep, waking the patient back up. It has to do with the fact that once you establish the sheath into the carotid, the procedure is so straightforward in most cases that it's hard to mess it up, so to speak. So what is the data for TCAR? Well, the Roadster trial was the IDE trial that got approval for the device. This is a prospective single-arm multi-center trial looking at the in-route transcarotid system during CAS procedures. This pivotal trial enrolled 141 patients at 18 sites. About another 100 patients were enrolled as part of their continued access. This included both symptomatic and asymptomatic patients, with surgical high-risk patients only in the initial Roadster 1 trial, looking at 30-day stroke death and composite stroke death and MI. The results are shown here. So the first thing to point out is that in terms of if you look at our intention to treat group, the major stroke, 0, there were no major strokes in the trial, minor stroke 1.4%, and if you look at stroke and death, 2.8%. And so this, if you compare some of this to some of the numbers we've already seen from the other carotid stent trials over the years, this is really best-in-class type data in terms of stroke prevention or perioperative strokes and stroke complications. If you look at symptomatic patients, so looking at a couple of different cohorts, obviously we know that symptomatic patients generally have higher rates of perioperative stroke when undergoing carotid stenting than asymptomatic patients. There were no major and no minor strokes in those symptomatic patients, and a stroke and death rate in symptomatic patients of 2.8%. So again, quite good data. Certainly we know from a number of studies, some of which are listed here, that octogenarians and people of advanced age typically have higher rates of stroke when undergoing carotid stenting than patients who are younger in age. And this is obviously an important area to look at in the Roadster trial. And in fact, we found in the Roadster trial, there were no major strokes, no minor strokes. Stroke and death overall was 3.0%. So this suggests, at least in this relatively small registry, that even octogenarians do very well, and this is very distinct from most of our carotid stent trials. And when we compare Roadster, the results in Roadster, the perioperative stroke rate in Roadster to some of the other trials, I would argue that this 1.4% stroke rate really represents a new bar that is akin to even the asymptomatic carotid endarterectomy patients in Act 1 or CREST. So what are the problems with this data? So I think Dr. Rosenfeld is going to point out that this is a small, non-randomized trial. It was also a trial done with highly experienced carotid interventionalists as well as highly experienced and high-volume carotid surgeons. And strangely, this trial and its resultant data really definitively changed the way carotid therapy is done in the U.S. now. So I think my title was for this talk is TCAR going to change practice or become the new standard? I would argue that it already is, because as surgeons, we've adopted this full bore. Any surgeon that has access to this technology is using it more and more in their practice. And I will admit that it's a little strange how well this has been adopted with this small data set. This was a non-randomized trial, which not only achieved FDA approval for the device, it also led to CMS reimbursement for asymptomatic high-risk patients, which is something that those of us who have done transfemoral stenting for a while have really sought for many years now with transfemoral stenting, and still has not been achieved. The other thing that was interesting is the rapid access and adoption by the vascular surgical community, often in surgeons who really have little to no carotid stent experience, and even our own guidelines in our SVS guidelines really don't emphasize the fact that you need any carotid stenting experience. It really emphasizes you have to have carotid surgery experience and familiar with 014 platforms. And so my initial take on this is that this is going to be a problem moving forward, and as new data comes out, especially real-world larger centers, I thought we would see much higher rates of stroke in some of these data sets. Now, has that been the case? So obviously, with transfemoral stenting, you've already seen this slide, really over the years we've had a decrease in stroke rates as our technology has improved, but probably more important than that, we've seen a change in stroke rates. Sorry, I'm having trouble advancing here. Change in stroke rates with some of our patient selection and our operative experience. So even the Sapphire trial, which is maybe the first large randomized trial that looked at DAPT, it had DAPT included, had embolic protection devices mandated, even that had a relatively high stroke rate of around 6%. And so the stroke rate of 6% and the composite endpoint of about 8% still wasn't ideal compared to CEA. And despite some of this type of data, CAS access remained somewhat limited for interventionalists. The credentialing remained very restricted, and we really started focusing on patient characteristics, lesion characteristics, and the importance of high-volume operators and keeping your experience and your practice up. So that again would suggest that as we roll TCAR out to the masses, so to speak, we're going to have some problems. In fact, that was not the case. The VQI registry is a very robust registry looking at clinically relevant endpoints in patients undergoing vascular procedures. Most large academic centers use the VQI for much of their data collection. And when this data set has been analyzed by a number of authors now, we've really found that TCAR holds up even in a broader population and broader access. On the study on the right, the learning curve for surgeons adopting TCAR, this procedure showed shorter procedural and fluoroscopy times for advanced operators versus novice operators. However, there was no difference in stroke, death, or composite endpoints between groups of either novice, intermediate, or skilled operators. Another paper shown on the right here demonstrated that among the 247 participating centers in the VQI that do TCAR or that do carotid interventions, the availability of TCAR at a center was associated with a decreased likelihood of major adverse cardiac events or cardiovascular events after carotid revascularization. So that basically says that if you do TCAR at your center, your rates are lower than the average center. So as this is rolled out to individuals and centers, we have not seen an increase in problems or complications. Finally, looking at some comparisons, this study by Schemmerhorn from 2019 looked at 3,200 propensity-matched pairs. There's a typo in the second line there, but they showed no difference in MI rates between patients undergoing TCAR or CAS, but did show that TCAR is associated with a significant reduction of in-house stroke or death with very significant relative risks. This study looked at over 100,000, it's not a million there, it should be 118,000 patients treated with TCAR, CEA, or CAS, so it compared all three. Same population. This was published in the Journal of American Heart Association, and this study showed no difference in stroke and death at 12 months between TCAR and CEA, and both TCAR and CEA were superior to transfemoral stenting in terms of stroke and death at 12 months. Finally, this study looking at TCAR versus carotid endarterectomy, again using the VQI data set, 12,000 propensity match patients. TCAR showed a significant risk reduction in terms of postoperative MI and cranial nerve injury, and no difference between the two arms, meaning those undergoing CEA and those undergoing TCAR, in terms of in-house stroke or death. So in the interest of time, I'm just going to skip forward. This is just one of the studies showing that this holds true even in the VQI data set for octogenarians. So I think that in conclusion, there's abundant data demonstrating that TCAR is associated with stroke rates equivalent to CEA and below those of CAS. TCAR is associated with low rates of perioperative MI and nerve injuries, and so that's a favorable benefit compared to CEA. And I think that adoption of TCAR by the vascular surgical community has been rapid and widespread, but has not been associated with increasing complication rates, despite the really limited experience with transfemoral stenting in some of these operators. For that reason, I think TCAR will continue to evolve as the dominant method of carotid revascularization. Thanks.